thank you all for coming to Grand Rounds. For the people that are in the room, on their way to the room, and those that are online, it is my distinct pleasure to welcome Dr. John Ryan to give us Grand Rounds. So I met John in 2005 when he was an intern at Boston University, and I was a junior resident at the time. As I was trying to reflect on how to introduce John, I was trying to say, what can I say about John that is not inherently obvious? You know, he was a star right from the beginning. He went on to become a chief resident at Boston University. He did his initial medical training in Cork, Ireland. Then after he did his residency and chief residency at Boston University, he went on to University of Chicago, where he trained in cardiology, pulmonary hypertension, and advanced heart failure. He subsequently was recruited to the faculty at the University of Utah, where he is now professor of medicine and leads the pulmonary hypertension clinic. He also is the program director for the cardiovascular disease fellowship. In addition to doing lots of research, publishing more than 150 peer-reviewed articles in leading medical journals such as the New England Journal of Medicine, CHEST, JAMA, Nature Medicine, and the list goes on and on. He also serves as sports medicine consultant for the US Olympic Committee, as well as the NBA, among other things. He loves to ski. He's the father of three wonderful daughters, and he's just a consummate clinician. And I'm delighted that you chose to use a case-based format to give your talk on pulmonary hypertension. And I'm sure you all enjoy Dr. Ryan. John.
Great, thank you. Well, thanks for having me. I just noticed on my slides, terribly sorry that this says health instead of heart, but I guess it's synonymous. So thanks for coming out on a Monday morning at 7 a.m. We used to have our conferences at Monday morning at 7 a.m. and but then we changed them to Wednesday at noon, and which just to plug is not a bad thing, and. And we have folks online, John, at this stage, don't we? And John has done a nice job coordinating everything. And it was a real treat last night having dinner with Kasia and Manju, who hopefully is online as well, or at least I know they have some fellowship meetings this morning, and then Hyen as well. Thank you, Edwin, for inviting me, and also for the nice words. You know, the remarkable thing about Edwin is that these photos are from 20 years ago. And I think we'll all agree that the man does not age. They could be from last week. And I in particular love this one. I mean, this is male model level, I think. And just as we all know, is a very welcoming person and a very kind person, and kindly invited me to talk today. The bulk of what we're going to do, we'll be talking about the Dyspnea Clinic. The Dyspnea Clinic is something we set up about 15 years ago at Utah. And the idea is that it is symptom-based, is patient-based, for example, and not to be facetious, but patients do not come in and say, I have pulmonary hypertension, or they do not come in and say, I have HFpEF. They come in and say, I'm short of breath and I'm miserable and help me out with my shortness of breath. And as all of us have experienced, either as providers or as patients or as loved ones being patients, it is almost invariable that when they come in with shortness of breath and they see the cardiologist will say it's not your heart, and then they see the pulmonologist will say it's not your lungs, it's your heart, and it ends up being this cycle. So we built up this dyspnea clinic with both cardiology and pulmonary to try and address this concept of shortness of breath. And to a certain extent, though, and I talked with this with Kasia last night, to a certain extent, it was a little bit of a ruse, because 15 years ago, first of all, there were no treatments for HFpEF, no more than there were no treatments for amyloid or HCM at the time. There were no treatments for HFpEF, and there was actually a lot, people were fairly skeptical that HFpEF actually existed, heart failure preserved ejection fraction. And because when Edwin and I were young, the only disease state that caused heart failure was systolic heart failure. And looking back at, for those of you who trained in the UK and Ireland, we had a book, and Edwin had this book as well. It was called Kumar and Clark. And maybe folks online are familiar with it. And your diagnosis with heart failure was pulmonary edema with a large cardiac silhouette. And if you did not have a large cardiac silhouette, it was not heart failure, it was something else. And that really is just so inaccurate. And then the other aspect is that 15 years ago, there was a lot of nihilism about pulmonary hypertension, that pulmonary hypertension, there was no treatment available, or whatever treatments were available did not impact prognosis and so on. So we knew we weren't going to get referrals for HFpEF. We knew we weren't going to get referrals for pulmonary hypertension, and but we knew it was out there. So we ultimately set up the Dyspnea clinic to try and address that and get some clinical trials going. The other aspect and kind of the hidden curriculum here is that it does require significant interactions and collaborations with already cardiology and pulmonary, but also radiology, surgical teams, geneticists, etc. And that is kind of part of what we want to show here. The final aspect, and I know Jack is a trainee, I'm not sure how many other trainees are in the room. Jack, if it's just you, you're getting all the questions, man. But the other aspect is, and this is what in particular we were talking about last night, is that as we go through these cases, ultimately you will find that every diagnosis, despite the $1 million workups that we're used to and the cardiac MRIs, et cetera, that we do, every diagnosis could have been and should have been made on history and exam. So for all the fancy things, ultimately, if we had taken a better history or a better exam, we would have gotten the diagnosis. And that's kind of the other part of the hidden curriculum here over the next 120, 130 minutes. So really settle in here. Yeah. So our first case is a 19-year-old lady from Idaho who presented with respiratory failure after a blood transfusion for severe menorrhagia. She had been raised in a rural community which did not engage in healthcare, which is perhaps common in your state. It's certainly common in my state, and in particular in Idaho. And she had been experiencing cyanosis and syncope for about 2 years before emancipating herself from her family. And so really, this was something that had at least been going on for some time. This is hard enough to see, and I'm not suggesting we dim the lights because otherwise everyone will fall asleep. But Jack, we might lean on you. This might be the first of many questions for you. And is there anything, and if you don't see it, we'll blame the lights and we'll lean on Edwin. But to explain, Jack, do you notice the difference between this lady's right hand and her left hand? And if you don't, I support that. But is there, first pass, do you notice a difference between her left hand and her right hand in terms of the appearance?
Oh, maybe the left one's a little bit, some scratches,
okay,
bruises.
Yeah. Any color difference between left and right?
No, I don't see.
No, you don't see any. And maybe the Edwin, from where you are, can you see a color difference if you?
Some cyanosis on
the left. Perfect. Yeah. So there is some cyanosis. Now that Edwin says that, Jack, do you see that now? So this is a darker hand than this hand. So her left hand is darker than her right hand. And actually with that, and hopefully most folks see that, or if you don't, I'll show you the ABG. So on her ABG, John told me not to walk around too much. I'm going to defy that, John. So on her ABG, on her right radial artery, you've got a PaO2 of 86, and on her left radial artery, you've a PaO2 of 51. So that cyanosis that Edwin pointed out is present, and your methemoglobin was 0.8 and 1.3. Well, the big difference is this oxygenation difference between the left and the right hand. And I suspect we have 3 fellows here at the back, namely 2 fellows. Any fellows? 1 fellow? Wonderful. What's your name? Oh, great. Wonderful. I love the term advanced heart failure because it's like, you know, do you want to see the heart failure doctor or do you want to see the advanced heart failure doctor? You know, and there's a real, sounds like a real difference there. Maroon, is that the name? Wonderful. And our friend in the jacket? Jimmy, wonderful. What's your plans after this? Oh, wonderful. Great. So you have this difference. Jimmy, do you want to make a comment on this, or is there anything you're concerned about so far? or you want more data?
More data is great, but differential cyanosis is hard to explain.
Wonderful, yeah.
But relatively specific.
Wonderful.
It's probably not intracardiac shunt.
Not intracardiac, cool, wonderful, okay. And then you have your ECG here for the sake of this crowd. I'll just highlight things that you will see here. You got this tall dominant R wave on V1 and also V2. And then you have this remarkable right axis deviation with a large AVF here pointing upwards and a large V1 going down. So your tall dominant R wave, I have no doubt that Edwin and the EP folks get very excited that tall dominant R wave could be Wolff-Parkinson-White or Duchenne's muscular dystrophy and all these things, but it's right ventricular hypertrophy 90% of the time. Don't let Edwin fool you. And so there we go. Edwin, anything else? Right atrial enlargement, I guess, or anything else that you'd call out here?
No, there's no WPW for sure.
No WPW, yeah. No matter how hard you look. All right, Maroon, talk us through this echo. Actually, before we do this right-sided echo, because Jimmy, I might go with you on that one. Maroon, what do you notice on this, and these echoes? Short axis and then long axis, and they're labeled, obviously, just for the sake of time.
Yeah, the RV is way more much bigger than the LV.
Wonderful. Any other kind of structural issues or kind of hemodynamic issues almost?
Systolic and diastolic septal flattening.
Yeah.
Perfect. Yeah. So you got this flattening of the interventricular septum, which for those who don't look at echoes for a living, also known as electrophysiologists, you have interventricular septal flattening, and so your right-sided pressures are at least close in size to your left-sided pressures, resulting in that interventricular septal flattening. There's some caveats there, Jimmy, which maybe we'll talk about kind of afterwards, that we can touch on. The other thing I would point out, Maroon, is that your right atrium is bigger than your left atrium as well. And also you have interatrial, at least septal flattening, as well as potentially bowing. Maroon, we'll keep going here. And then Jimmy, then if Maroon doesn't pick it up, I'll probably lean on you. Are there any other fellows then at this stage? Oh, wonderful. Sorry, what's your name? Abel? Wonderful. What's your career plans?
I want to do imaging.
Imaging, wonderful. Yeah, let's go with you, so Abel. What do you notice on this one, or do you notice, or this is pulmonary artery for those, again, who don't look at this for a living. This is the pulmonary artery here, dilated pulmonary artery, and then it branches into the left pulmonary artery and the right pulmonary artery. Abel, anything that you notice here?
Flow after the branching.
Wonderful.
I'm not sure where it's coming from.
Wonderful. Abel is spot on. So you got this color flow here, as you point out, not sure where it's coming from. This is the right pulmonary artery area, or at least the end of the main branch of the pulmonary artery. So I'll encourage you to start thinking about what Jimmy said about this differential cyanosis is not normal, difficult to diagnose. Go ahead, Jimmy. You have a feeling about something?
About where it's coming from, if it's truly continuous or if it's systolic only.
Perfect.
In that image.
Perfect. Yeah. So what Jimmy's bringing out is that you got this color flow. Maybe not every heartbeat, but certainly abnormal, as Abel pointed out. On to the next slide here. Okay. So Center for Right Heart Cath, Maroon, I think, wanted more data, and Jimmy wanted more data. So Center for Right Heart Cath. PA pressure is wicked high, 71 for a mean PA pressure. Wedge is 10, so it's not HFpEF, if you ever had any doubt. Cardiac output is 3.8, and then pulmonary vascular resistance is 16. SVC stat of 68, Jimmy, will lean on you here. SVC stat of 68, PA stat of 62, venous stat 90, and peripheral stat of 78. So again, significant drop off. There's no step up from the main pulmonary artery to the branch vessels. So to your point about the systolic flow or the diastolic flow, kind of what does this suggest to you in terms of at least the directionality of the flow?
Right to left shunt.
Perfect.
After the level of the pulmonary vein is all we could tell.
Perfect. Yeah, so somewhere between the pulmonary artery and the pulmonary vein at least. Wonderful. Good job. Okay. We do a CT scan, Abel. You're welcome. We do a CT scan, and Abel, we might lean on you here. I'll play it maybe once or twice, or maybe 3 times, depending on kind of how long you want me to play it. And but I do anticipate. God, I'm going to put pressure on you here. I was about to say I anticipate you'll find it. Is Hyan on at this stage, John? Or can you check, please? So here you go, Abel. Right ventricle for those uninitiated, left ventricle here. And then Abel, do you know? And then I'll play it one more time for you, Abel. Actually, I'll play it 2 more times for you. It's 7 o'clock on a Monday morning. Your aorta here, your pulmonary artery here. Okay, Abel, last chance. Right ventricle, right atrium enlarged, as we said, pulmonary artery, aorta. Anything you want to point out, Abel?
PDA.
Wonderful, wonderful. So there is, between this pulmonary artery and between here, there is a communication, and as Abel rightly points out, that's a patent ductus arteriosus, or PDA. Edwin, have you seen many PDAs in 20-year-olds?
I don't see too many adult congenital heart disease patients here, unless if they have rhythm issues. But
But even over 20
No,
years or
no,
so, yeah, you don't see
no.
that many adult PDAs, and especially for those more senior folks in the room. But again, it kind of makes sense if we go back to this hidden curriculum, and I think Jimmy and Maroon and Abel, I'm not sure if you're here at the time. If you go back to this hidden curriculum, we had this diagnosis almost from the very beginning. We had 2 years. We had, I'll tell you, there was a murmur there. Jack, do you know what murmur that this lady would have had? I have a recording, but I didn't include it here. I don't remember the murmur you get. Jimmy, do you want to help him out?
Continuous machine.
Perfect. Continuous machinery murmur. So systolic and diastolic, because again, these pressures are so high, 90/60. Her systemic pressures were actually lower at the time. And so continuous machinery murmur from the right to left shunting. This then just reinforces what Abel nicely pointed out: huge pulmonary artery. And then here is your pulmonary artery, and here's your aorta, and you can see this large communication between the pulmonary artery and the aorta. And then, as Abel pointed out, on the 3D view, you can absolutely see the pulmonary artery there. Do we have any other imaging folks here aside from Abel? Otherwise, we'll lean on him. So MRI folks? No MRI folks. Okay. Sorry, man. You're up again, Abel. Actually, I'll show these images and then I'll talk you through it. Let's see. Yeah. So this kind of speaks to it. So this is the cardiac MRI, or at least it's not. It's a mixture between a cardiac MRI and aortogram. And I'll play it a few times. And this one I won't lean on you about because it's pretty, or not complicated, unless you want to weigh in. You don't want to. Okay, that's fair. So what I'll show you, absolutely understandable. What I'll show you is, whoops a daisy. I'll go back to the beginning here. So this is your left, this is your left ventricle here. Your right ventricle is here at the front. Really should be called the anterior ventricle, but when Vesalius took it out, he turned it to the right and called it the right ventricle, and 400 years later, here we are. So here's the right ventricle, the left ventricle, and then the aorta coming down here. So what you will see is that the descending aorta will fill first, and then the ascending aorta will fill. And this speaks again to the right to left shunting that Jimmy made reference to, and Maroon was concerned about with the color flow, is that your right ventricle is filling, and then it is pumping into the descending aorta through the PDA because of this right to left shunting, and also known as, goes by an eponym, right to left shunting, severe right side elevated PA pressures resulting in right to left shunting, goes by Eisenmenger's. Wonderful, yeah. So this is essentially an MRI of Eisenmenger's physiology. So again, the right ventricle will fill, you'll see the descending aorta fill, and then ultimately the left ventricle and the ascending aorta will fill. So let's, now that I've told you that, let's take a look. So your right ventricle, there you go, and your descending aorta fills first. You don't see the right ventricle fill a whole lot actually on this one, but you do see the descending aorta fill first, and then the ascending aorta fills in. So again, reflective of this communication from the right ventricle to the descending aorta and this right to left flow consistent with Eisenmenger's physiology. And for those who didn't believe that, whoops a daisy. For those who didn't believe that, here's the ventricular filling. Yeah, here is the right ventricular filling, again, the anterior ventricle. And then your descending aorta fills, and then ultimately everything else fills. Right ventricle, descending aorta, and then everything else fills from there. The ascending aorta fills from there. Maroon, advanced heart failure, what do you want to do?
Well, it's complicated because, I mean, usually for PDA, the best option is closure, but
Exactly, yeah.
in setting of Eisenmenger, it becomes a contraindication to close
Yeah.
the PDA.
Yeah. Do you want to tell folks why it is a contraindication?
Because they're dependent on the shunt.
Perfect.
Basically.
Yeah. And that was the struggle that we had as well. And the other aspect is if you recall from the CT scan, it's also very, very large. So it's certainly not something that you do percutaneously, even it would require surgery. So we struggled with that as well. So you're reluctant to do surgery. So what do you want to do? Palliative? 20-year-old? Just emancipated yourself from a family?
Not quite.
Not quite. Okay, good.
To advanced heart failure.
Yeah, that's a fair point. Do you want to transplant her?
She's definitely would
Yeah.
be a consideration.
Yeah, she definitely meets transplant criteria. The challenge, of course, again, is that she is 20, which is because she would also require lung transplant as well as heart transplant, which is hard. So we struggled a lot with her, and we ultimately started her on oral and parenteral prostacyclins, specifically treprostinil. And we did refer her for a lung transplant. I think everyone was concerned about the kind of life expectancy with that. And 10 years later, she's been on pH-specific therapies and has actually done very, very well. And so ultimately her diagnosis is Eisenmenger's physiology, or Eisenmenger syndrome, as our fellows pointed out, with non-repaired patent ductus arteriosus. So we did this case, and she did very well. And then I got a call truly on a Tuesday afternoon in my office, and it was a phone call, and it was, "Hi, this is Melissa from the Today Show." I was like, "All right, Melissa," and this is amazing. I've been waiting for this call my whole life. And she said, "We're doing a feature on your patient tomorrow whose healthcare was, she did not get healthcare for religious reasons, and within the state of Idaho, you can choose to," and I'm truly not getting political here, but just to give you context, you can choose not to give healthcare to family members for religious reasons, and then it's for freedom of religion, etc. And they said, "So we want to do a feature of this on the Today Show tomorrow, and we're wondering if you have a comment." And hung up the phone and called my PR department and said, "Today Show wants to do a comment about religious freedom and withholding healthcare based on religious freedom." And they said, "You are not doing this tomorrow." And which is understandable. Okay. This is a wonderful man. So our second case is a wonderful man who, 47-year-old. Oh yeah, Maroon.
Sorry, I had a question.
Yeah.
Would there have been any concern with pulmonary vasodilators in setting of PDA specifically?
Yeah. So her wedge was low. Her wedge was 10, as you will recall. So we were less concerned about kind of because her left ventricle is compressed, as you pointed out. And ultimately, it is not common for congenital heart folks to respond this well to pulmonary vasodilators or pH-specific therapies, because typically it is such a hyperproliferative disease, namely medial hypertrophy, as opposed to vasoreactive or vasoconstrictive, which is more common with our, say, methamphetamine population, for example. So you're right. And did you have any other concerns with the PDA?
So my other question was, why wasn't she, or maybe she was, on Bosentan or any...
Yeah, ultimately, prior to that, because... So she truly had gotten no health care until she gotten that blood transfusion from Asia. So yeah, so we got her on triple therapy. Yeah, so we got her on triple therapy. Yeah, nice question. Wonderful. So this is a 47-year-old man, former mixed martial arts UFC fighter from Nevada. As Edwin made reference to, I'm one of the cardiologists for United States Olympic Committee, which is actually probably the best thing or among the best things that I do. It is actually, especially not being from this country, it is actually an enormous privilege to be able to do that. So I felt that I should, as UFC was growing, I felt that I should be the cardiologist for UFC. So I wrote a letter to Dana White, and I said, "Dear Mr. White, I would like to be the cardiologist for UFC." And I never heard anything. And then sometime later, I ended up talking with the head psychologist for UFC. And I said, "Listen, man, like I really wanted to be the cardiologist for UFC. I would have done a really good job." And he said to me, he said, "You know, we looked, John, at your stuff, and we just felt that you had too much integrity." And I was like, huh. So one stage I was kind of offended. I was like, "You don't know me very well." But in any case, we built relationships over time, and this gentleman came to us. He's from Nevada. He actually came to Liver Clinic initially and had elevated LFTs and 35-pound weight loss, nausea, vomiting, diarrhea. So let's see, Maroon, you don't get a whole lot of people with 35-pound weight loss. Most of your patients are weight gain. So we did an exam, and again, as part of the hidden curriculum, everything was there in hindsight. Same way as it was with our other lady. Normal S1 and S2, big liver. For those of you, Jack, you can percuss a liver edge. I don't know if you do that. Used to be a thing that we did, and maybe not anymore. And then he had a little bit of peripheral edema. Okay. Past medical history of concussions, hypertension, unsurprisingly, concussions. Also unsurprisingly, chronic pain from musculoskeletal injuries and fractures from competing MMA. Right shoulder surgery, foot surgery, and a 20-year history of performance-enhancing drugs, including testosterone, that he stopped 8 months ago. So that's kind of your first thing. I will say that when I was talking with Hyan last night, I did obviously learn of your own methamphetamine, kind of significant methamphetamine use in this town. So that's obviously one thing we were concerned about. We have a lot of methamphetamine in both Nevada and in Utah. So that's within the performance-enhancing drugs. That was one thing we were concerned about. And it's funny though, Edwin, one of the remarkable things that I remember when we were together is, and this is just an anecdote in relation to the methamphetamine, is that we had the only case of thyroid-related heart failure that I've ever seen. And it was this lady who flew into Logan, big neck. We were with Henry Uwe at the time, and it was thyroid-related cardiomyopathy. And it's bizarre to me, Jack, how when every patient gets admitted to the hospital for heart failure, everybody gets their thyroid checked. And I don't know if it's like this in this town, but no one gets methamphetamine checked. And then they say, "Oh, well, you know, they don't look like they use meth." I'm like, "Well, they look like they have a thyroid problem." And I don't know what using meth looks like. But in any case, so we check everyone. Within our program, we check everyone for methamphetamine. Our average age of methamphetamine is 55. So as opposed to others. But so we checked him for methamphetamine, and we didn't find anything. But his LFTs were very abnormal. ALT of 1100, AST of 219. So in particular, that ALT. Here we have right bundle branch block, maybe incomplete right bundle, but at least a right bundle nonetheless, in our opinion at least. And then that's kind of the main abnormalities that we see here. All right, Maroon. Unless another fellow has arrived since we started. Any comments here? Kind of quick highlights?
Yeah, big liver.
Big liver, yeah.
RV is big, and pulmonary artery is big.
Wonderful. Yeah, so what Maroon points out is that right ventricle is big, and liver is very big, right? Consistent with physical exam findings. Okay. Kidney's probably a little big as well, I would say. Okay. Let me push you a little bit, and Maroon, am I pronouncing your name correctly? Okay, wonderful. Let me push you a little bit here. So you have contrast here, and you have contrast here, right, in the LV. Is there anything else that's lighting up that's bright?
That is an aorta.
Aorta is bright, vertebra is bright, ribs are bright, anything else that's bright? And there is. I'll give you a lead here and tell you that there is something else that the RV and LV both have contrast in them, the vertebrae and the ribs obviously have calcium in them. Is there anything else that is bright that doesn't normally have contrast in it and doesn't normally
Coronary
have
sinus.
Coronary, you're referring to this area here, Jimmy? Yeah. So what Jimmy points out appropriately is that you have this brightness here outside the left ventricle. So fairly thick brightness here outside the left ventricle. I'll tell you it's not coronary sinus. This isn't a great, this was a liver scan, CT liver. So it's not dedicated for this, but I will say it's not coronary sinus. But it is bright. Okay. And IVC is dilated as well. Okay. So this is a liver biopsy. I've no doubt that everyone here is used to looking at liver biopsies. I'm sure you do it all the time. And Adele, we'll have you, or Abel, we'll have you comment on the liver biopsy here, the key findings here. And I don't need to ask you because I know that instantly you will point out. So what you do see here is that this is more red than this area. You'll see this is paler. Do you agree with that? Is that visual? That's perfect. And that's some congestion and dilation around the, so this is basically, there's fluid in this area, which is why it's paler than the red areas. And then when you do your reticulin staining, as standard, you can see there's extra fibrosis there. So, and loss of hepatocytes around that area with the reticulin staining. So now you truly do have some sort of pathology in the liver. You have a big right ventricle, such as Maroon pointed out, and you have this outside area. So I know what you're going to say next. You're going to say, I want to do liver hemodynamics, right? That's what everyone wants next, right? Maroon, you've done liver hemodynamics all the time. And the reason to do liver hemodynamics is because you want to see, is this, or at least can you imagine why you want to do liver hemodynamics? I know you probably have never conceived, conceptualized it.
To see if it's post-hepatic or pre-hepatic.
Perfect. Yeah, see if it's post-hepatic. So you can see here, right atrial pressure is 12, hepatic venous pressure is 12. You then do a wedge of the liver. So for those of you on your heart failure rotations, you can ask to wedge the liver. It will go very well. And then you have a portal vein gradient of 1. So what does this suggest to you, Maroon? Post-hepatic, so congestion. Wonderful, exactly. See, you guys got liver hemodynamics. Yes, my friend.
And certainly, like, I understand the logic behind it, but with a JVP of 15, that's north of the liver, you already kind of infer that.
Oh, sure, because you already feel that it's post-hepatic. Yeah. A lot of this was based on the fact that we wanted to make sure that there wasn't a vascular component to it as well, because his ALTs were so bad. Yeah. So yeah, you're right. But post-hepatic portal hypertension secondary to right heart failure.
Those measurements?
Oh, you just stick it in there. You go past the SVC, you go past the right atrium into the IVC, and you stick it in. It's easy. Blow up a balloon. You don't blow up your balloon. You keep going through. Yeah. The capillaries are small. Okay. Anything, Abel, do you want to comment on this one real quick?
There could be possible ventricular interdependence with this.
Wonderful, wonderful. Yeah, wonderful. So in comparison to, and this is one of the things, Jimmy, and the rest of the cardiology fellows that I want you to try and remember, is that interventricular septal flattening is kind of almost, it's kind of like a little league term. You know, you got to try and define it a little more, because people could say, now Belsa didn't obviously, but you could say that this interventricular septal flattening, but you noticed in a more sophisticated way that you got this kind of whip-like manifestation of the ventricle. So can you piece this together, Bel?
Yeah, so.
Or what does interventricular septal flattening mean, I guess? Do you want to share?
Yeah, so that means that well, in this case specifically, when during the respiratory cycle, there's pressure variation between the right ventricle and left ventricle, where during inspiration, the right ventricle pushes into the left ventricle, and then when there's relaxation, you can see the
Perfect. And then from a pathology then, what does that suggest to you?
That makes me think possibly about constriction.
Perfect. So what Abel just mentioned for those who are online is that he's wondered about the interventricular septal flattening and then constriction. And then Jimmy, this goes back to your observation about this calcification outside the left ventricle, or at least this contrast outside the left ventricle, which now we felt was pretty consistent. Sorry, not contrast, this brightness outside the left ventricle, which we felt was pretty consistent with calcification. We do the hemodynamics, the right atrial pressure is elevated and with a steep Y descent. And then more classically, Abel, let's get you to wrap. Oh yeah, actually, you have this decrease as your LV pressure decreases, your RV pressure increases. So consistent with constrictive physiology, such as Abel already picked up. So then we went back and had a history. And despite the fact we were worried about testosterone, despite the fact we were worried about methamphetamine, none of that was present. And we went back and took a history. And as it turned out, in fact, sorry, I'll take a step back. The medical student went back and took a history and learned that he would get kicked in the chest for 4 hours a day, 5 days a week, over a 20-year period. Turns out that's not great for your heart. And then we took him to the OR. He had very calcified and thickened pericardium. He underwent a pericardiectomy, and we did histology here. Now, no doubt, as good as you are, Abel, with liver biopsies, your pericardial histopathology is probably top-notch. And ultimately, he had a lot of fibrosis here and chronic inflammation. And some blood, some hemosiderin deposition as well, which pointed to chronic trauma from his recurrent kicked in the chest 4 hours a day, 5 days a week. And so yeah, I do have integrity. We ended up taking care of him, and we took such good care of him. This man is amazing. So he lives in Aurora, Nevada. He will frequently send pictures of various things that he likes to do in Aurora, Nevada. Most of it, I'm not sure how legal it is. And he sent me a note. You can see this is dated a little bit ago, but he sent me a note and he said, Dr. Ryan, there was a Hershey's kiss in the envelope that he sent me. He said, I just wanted to say hello and give you a big old kiss for saving my life. Thanks again. You need anything, you call me. Which, when a former UFC fighter living in Nevada says that, you know, he will do anything. All right, our final, but again, looking back, you know, we should have gotten this from the history earlier, or we could have gotten this from the history earlier, and certainly there were features on the exam, albeit he didn't have a pericardial knock, funnily enough, I don't know why. And so our final case then, 18-year-old gentleman from Idaho, new onset, increased shortness of breath. Resolved at rest, beginning worse. 1 month prior to his symptoms, or at least what I remember as symptoms, he woke up and had right arm swelling. PCP sent him to urgent care. Urgent care, understandably, I mean, ultimately he's a rare case, but urgent care said he was sleeping on the wrong side, gave him an inhaler. Family was concerned, and then they took him to the emergency department. In the emergency department, the bottom line, the impression is the most relevant, at least. He had extensive thrombus in the right upper extremity. So right upper extremity DVT. Common, Jimmy? No, not that common. And you always have to, there's an adage that Elaine Heileck would tell us that if you had a right upper extremity DVT, you got to chase it. There's always an abnormal pathology behind an upper extremity DVT. Lower extremity DVT, you can be a little permissive, obviously looking for provoked versus unprovoked, but right upper extremity DVT, you always have to chase. This is kind of similar, dilated pulmonary artery, and kind of big right ventricle, big right atrium. So similar enough. What about here, Maroon? What do you think of this and this?
Edema, there's not enough blood.
There's not enough blood. Yeah, there's certainly not enough blood. You said edema, is that what you said? Oh, oligemia, wonderful, thank you. Yeah, I agree with that. You really have nothing there. And then what about this here?
Also, yeah.
Filling defect, wonderful, wonderful. And then one more, Abel, we'll go with you on this one from the advanced imaging. Hopefully this, yeah, I think you can see this. Yeah. What about this vessel here, Abel? Is there
Looks like
anything
there are
abnormal?
multiple lumens.
Say that again.
Does it look like maybe there are a couple of lumens within?
Couple of lumens, wonderful. Or at least there's a couple of lines there. Is there any term that you would use for distal pulmonary vasculature with a couple of lines in between it? Okay. So web. So this is a web. This is what a web looks like. So with a web, is there any kind of disease state that you get concerned with a web? CTEPH, wonderful, wonderful. So you all are pretty concerned about CTEPH already. You know he has an upper extremity DVT, and he concerned about CTEPH. Again, a sound approach. He gets TPA, gets discharged on anticoagulation, and his arm swelling improved, and at least he felt that his shortness of breath resolved. So why would a young man have a DVT and upper extremity DVT and a PE? Any particular
Outlet.
thoracic outlets? Wonderful. Your team are good. They're better than you and I were by a long way. Yeah, yeah. You speak for myself. Fair. All right. This is upper extremity DVT, upper extremity venogram. I will ask Jimmy for your comment. I'll show the resting one, or at least I'll show you this one, Jimmy. Anything stand out to you here? I know you probably don't look at these for a living, but if you follow the flow here. Say that again.
Like above the clavicle, there's narrowing of the.
Perfect. So Maroon points out that above the clavicle, first of all, it's kind of slow in general, and then you have a narrowing here, right? Should be. You're concerned about the location of the clavicle.
On the right side, it's not. Yeah.
It's kind of highish. Yeah, I agree. So what do you want to do next? You were worried about thoracic outlet syndrome.
Referring for surgery.
So, so you're referring for surgery. What we did, which I know you'll agree with once I say this, is we raised up his arm. So again, looking for thoracic outlet syndrome. So we raised up his arm, injected the contrast, hopefully. Yeah, there we go. And now what you'll see is, or what do you see now?
Yeah. Obstruction.
Collateralization, yeah. So obstruction, as Maroon pointed out, and then as Jimmy pointed out, collateralization as well. And again, I will say this was present on exam, or at least some manifestation of this was present on exam, which we didn't do well enough. So so upper extremity DVT with some sort of thoracic outlet syndrome. I know this will roll off the tongue of most people here, so I'll just tell you. So this is consistent with Paget-Schroetter syndrome, right? I do sincerely know that you've heard, our fellows have heard of that. So Paget-Schroetter syndrome, venous thoracic outlet syndrome causing upper extremity DVTs. Done? Everything done, Maroon? You're happy? You want to go straight for a rib resection?
Well, why? I mean, he should have that, but why would that cause shortness of breath?
Okay.
It's weird that right upper extremity DVT would cause shortness of breath with inversion.
Wonderful. So he gets referred for a rib resection. And Abel, and it is Abel, right? Yeah, wonderful. Abel?
There's again septal bone.
So again, intraventricular septal flattening, and here?
And this temple.
This right ventricle is ginormous. It's not working very well. So to Maroon's point, it's unusual for a rib and upper extremity DVT to cause this. We've seen webs. So, and you have this massive right ventricle. So we referred, so we have another CT scan. You still see that one of the things that will encourage you to, in particular our fellows, to look for on your CT scans. Hopefully this is projecting okay. Maroon, can you see that this is kind of brighter than this area? Is that appreciated there? Okay, so this is the oligemia that Maroon was making reference to earlier, that you have blood flow in this area, for example, and you don't have blood flow in this area. You have it over here as well, probably blood flow here, no blood flow here, and I think there's one more. Yeah, this area probably is the most pronounced. Blood flow, no blood flow. So at this stage, I think we're all pretty comfortable that he has a lack of blood flow in this area. Yeah, and I will say actually, Abel, to the point that we talked about earlier, that you felt there were 2 lumens. Absolutely, it looks like 2 lumens, but it's actually a web. Okay, Referred for a VQ scan. We do SPECT imaging. When I was talking about high-end last night, it seems that you all, not a criticism, but are not doing SPECT imaging with the VQ scans. We find them useful, especially for surgical planning. And you can see that this absolutely speaks to, if for those of you, so this is the traditional VQ scans that me and Edwin grew up on. These are like Rorschach blots, to be honest with you, I find. It's like, what do you see? And it's like, oh, I saw my dog when he drowned in a river. So these SPECT ones are pretty useful, and you can see where there's significant dropout, the orange-yellow color being where there's blood flow, and then the other obviously being lack of blood flow. Goes through hemodynamics, PA pressure is 55, cardiac output low, wedges high because of interventricular septal flattening that Abel made reference to, and then PVR is wicked high, 11. So now we have a diagnosis of Paget-Schroetter syndrome causing chronic thromboembolic pulmonary hypertension. So we done? What do you want to do now?
For surgery.
For surgery, wonderful. So we had a couple of options. We felt pulmonary endarterectomy, rib resection, or pulmonary endarterectomy and rib resection. I will say just with Hyan's work, and this is a beautiful review article that he wrote when he was at Temple, I will say with Hyan's work, another perhaps more palliative to a certain extent, but sometimes symptomatic improvement. You could do an atrial septostomy as well, at least to offload the right ventricle. Kasha, on the other hand, I have no doubt will go straight to mechanical circulatory support and some sort of VAD of some sort. I'm not sure if Kasha is on, John, but this is one of her papers that was just published actually within the last month or so, who obviously does incredible work, as we know. So we were concerned about the pulmonary endarterectomy with the cardiac output, and we actually wanted to try a rib resection first. And there was just a lot of discussion about that, but ultimately we went for a rib resection. And you can see that actually with the rib resection, by resolving the recurrent clot, his old clot actually essentially resolved because he was no longer having these repeated clots. And a lot of debate in this field. We talked to folks in San Diego and Seattle and stuff as well to try and figure out the best approach. But ultimately, we did the rib resection, and within 6 months, or at least even after the surgery, there was a minor decrease, and then within 6 months, you have a much bigger decrease. Cardiac output came up a lot. PVR came up a good bit, and he ultimately did well. So we were then presenting this case. Part of the clinical conundrum was we presented this case to someone who used to be at University of Minnesota. Stephen Archer was his name, and we presented this case as part of grand rounds to Stephen Archer. And he said that his shoulders appeared raised, similar to what Maroon pointed out. And he said, could this be Klippel-Feil syndrome? And I was like, no. And then I quickly went to Wikipedia to look up what Klippel-Feil syndrome was. And it is a rare condition, abnormal fusion of any two of the cervical vertebrae. So you do get this upper chest change in the structure of the thoracic outlet. So we referred to him for genetic testing. And he was heterozygous for MYO18B. And MYO18B is actually a mutation associated with Klippel-Feil syndrome, and in particular myopathy and facial dysmorphism, which he had some. So this is just kind of your standard case of MYO18B causing Klippel-Feil syndrome, causing Paget-Schroetter syndrome, causing CTEPH. So you see this all the time. But ultimately, again, this was something, maybe not the mutation, but certainly the exam features, both of the thoracic outlet syndrome as well as obviously the Klippel-Feil syndrome, really could have been picked up on history at the very beginning. So those are our cases. This is our team, the Pulmonary Hypertension Utah Care Team. Also, you can sound out the abbreviation yourself. And we have a big team. As you'll notice, we have a big team. Some of us at the pulmonary hypertension meeting about a year or so ago, and it takes a lot to kind of put this team together. So that's kind of that's it. This is a real treat. As Edwin and I were saying last night, this was kind of long in the making in terms of coordinating this, mostly because of my trying to coordinate my both our schedules. But it's a real privilege to be able to present here and for Edwin to give the invite. So thank you very much. Don't forget to click like and subscribe, and I'll take any questions. Yeah.
Thank you, John, for a wonderful talk and introducing our fellows to the Socratic method. I mean, I feel like I'm back in the Harrison Avenue campus, except that I was doing this, but this is wonderful. Any questions? Anybody in the audience or from online?
So for the last case,
Yeah.
For CTAF,
Yeah.
Is it safe to assume that his functional class was class 3, basically he had symptoms with minimal exertion?
Yeah.
And if so, would an oral agent like riociguat also would be indicated in his case, or just surgery?
Yeah, so Marin asked a nice question. So there is some medical treatment available for CTEPH, specifically nitric oxide stimulator. It is, strictly speaking, it's approved for inoperable or persistent CTEPH. And we didn't, at least up front, we didn't, we wanted to see what surgery looked like up front. I do think we gave him riociguat ahead of his surgery. Common enough practice these days. And but then once his surgery was completed and we saw the PA pressures come down, we did ultimately get him off riociguat, and he's done well. But I do think this one of the three, I think this is one that really was complicated. We're all comfortable with PDA, or we know that PDAs should not be closed when pressures are that high. We know that removing the calcium and setting a pericardial constriction is beneficial, albeit a high-risk surgery. And but this one was the real multidisciplinary discussion. So I guess, I'm not sure if you were here at the time, but that's kind of the other part of kind of what we're trying to get across. And Kasia and I talked about this last night, that it does take a lot of folks to try and come to a consensus in this case, as well as in a lot of our cases. So you're right. Medical therapy would have been modestly beneficial, albeit not curative. CTEPH surgery would have been definitive, albeit difficult. And then we felt that giving him a rib resection up front was probably kind of the first thing that we wanted to do. And I don't know if we got lucky, Marin, or not, but certainly it worked. Yeah, yeah. But you could easily do CTEPH surgery. Yeah, yes.
I have a question on the first case.
Yeah.
Thank you. Had that young woman received medical care prior to age 19,
Sure.
would the lung transplant have been avoidable?
So we were lucky enough that, so had she received most PDAs, as any Jack and others will know, most PDAs, because of the murmur that Jimmy described, you recognize in the neonatal area, and then do you remember what you gave, Jimmy? Indomethacin, perfect. So you treat with indomethacin and it goes. Because it's prostaglandin mediated vascular injury. And so that happens most of the time. I think if she had been received care kind of at 10 or 12, but she was not in neonatal care. She, like a lot of people, was delivered at home and then did not receive care going forward. I think if she could have been picked up at 10 or 12, and I think probably closure at that point might have been more feasible. I don't know. Certainly her symptoms were going on for at least 2 years, which by epidemiological stuff kind of suggests that her disease state was probably going on 5 years at least. And so I do think an earlier intervention could have avoided the significant pulmonary arterial hypertension that resulted. And ultimately, but to make the point, we haven't done transplant up until now at least, and hopefully we won't have to in the end. John.
Yes, Dr. Ryan, thank you very much for your excellent presentation this morning. We do have one virtual question. It comes from Dr. Hayat Al-Maluli.
Oh, wonderful.
And he says, great talk, thank you. And his question is, would you close the PA after treating the PH?
Yeah, so we talked about that. The PDA, obviously, is what it means. Would we close the PDA after treating PH? And this also speaks to the offloading, such as what Marin made reference to in Amy Hines' paper here. Would we close it? And we've been hopeful that we can get the PA pressures down low enough to be able to do that. I have found that the guidelines, and this is not guideline, I guess maybe this is just more editorializing, I guess. I feel that the guidelines for closure of ASDs and PDAs are probably, in my opinion at least, are overly cautious. I think 2/3 is the cutoff, right, or something like that, that if your PA pressure is 2/3 of systemic pressure, then you shouldn't close it. And I think, in my opinion at least, that's overly cautious, albeit the typical recommendations. I think I would love to ultimately close it, but the challenge is that, as I said, Hein, as I said to Maroon, I think one is that, well, as Maroon pointed out, there is still probably some offloading associated with it. The other is that it is so large that I think it would require surgery. If it was a percutaneous closure with some sort of device, that would be easy. I think we would. And then also, as you know, with your device, you can do a fenestrated thing, or you can inflate with a balloon for 20, 30 minutes and see what happens, and then bring the balloon down if needs be, where surgery is a lot more difficult. So I would love to close it high at some point. But I think, and as I included your paper here, I think there's some benefit of offloading the right ventricle with these right to left shuntings, and so it just gets a little hard.
Thank you so much. These are the most fun cases ever to go through always, so I really appreciate it.
Well, thank you.
My question is, every time we present awesome cases, we are sort of always looking back at the primary care, giving an inhaler and sending them home, and kind of talking about the cardiologist who didn't do thoracic outlet physical exam testing at the initial visit, that sort of a thing. And with the volume of patients we're seeing now, I just think it's challenging to do a good enough history and exam on everybody. And so I think a lot of these things tend to slip through the cracks, and the more people we see, the more our approach becomes reactionary and shotgun approach rather than truly thoughtful at the initial visit with a patient.
I agree.
So I just wanted to make that comment.
Yeah, I agree, and I think first of all, that Harry Potter Hedwig's theme with my phone, so let me just silence my phone. So I agree. I mean, ultimately, I think the fact that we have the specialist referral center for the dyspnea, obviously by definition, folks are referred with cryptic dyspnea. But the biggest challenge actually I have is in the 20 years that Edwin and I have been here, and certainly a lot of folks here have been practicing for a similar amount of time, is the obesity challenge, I think, is the biggest, because there is no, at least in the pulmonary hypertension, and all these patients ultimately had pulmonary hypertension, there's no protective effect of obesity. So when Edwin and I were young, when most people had a BMI of say 28, and if they had shortness of breath, you kind of went down a diagnostic workup, such as you said, because their BMI was 28, they were young, they were 35 years of age. Now that kind of the BMI is, at least in large part, it's 42, and I think Kasia and I were looking over this last night, that in Minnesota, Minnesota, it is higher than Utah, say. Now that it's 42 or even 45, there can be a tendency to say your BMI is 42, your BMI is 45. The reason you're short of breath is because your BMI is 42, 45. You have dilated pulmonary artery because you have sleep apnea. And that's the numbers. The numbers suggest that that's right. But there's no all of these cases could have occurred in someone with a BMI of 42 or 45. So I find that so what I would caution you all is that, in particular, because HFpEF is HFpEF, just if you have big left atrium, left ventricular hypertrophy, you're probably, you're more likely done. But if you have a BMI of 42, 45, you should do just as thorough a workup for their shortness of breath, especially if they're young, than if their BMI was 28. That's the one that trips you up. The obesity is the one that trips you up. But there's no protective effect of obesity. It doesn't stop you from getting CTEPH or pulmonary arterial hypertension, etc. Yes, sir.
One last question on the second case of constrictive pericarditis.
Yeah.
When you take the pericardium out.
Yeah.
We had a case or two where when the pericardium was out, the tricuspid valve failed. Did you run into that at all?
Yeah. So the tricuspid valve failure, I think, so we didn't run into that there, but you're absolutely right, because then everything gets larger and your LV distends more and you have a lot more room in your orbit, you can kind of blow out as well. There's a similar, I don't like the term, but within the congenital heart disease area, people refer to, well, I'm actually not going to use the term, but you get acute right heart failure in the settings of doing some surgeries. So very, very bad right ventricle. So you can have that tricuspid regurgitation. And this will be music to the ears of your structural interventional cardiologists. Tricuspid regurgitation, again, when you and I were young, Edwin, we thought it was just appropriate and kind of passive and kind of like almost like mitral regurg. We thought that we'd allow it. The LV was dilated. Your tricuspid regurgitation is bad. You should, in my opinion, intervene on tricuspid regurgitation either with pharmacological agents such as stop low the right ventricle, or actually now that the interventional structural interventions have gotten so much better, I would encourage you to not sit on tricuspid regurgitation anymore, even if you think it's functional TR, which is a term that I don't know what that means. So there you go. Yeah, that may fly in the face of some other, well, I know it flies in the face of some recommendations, but I would encourage you to not feel that TR is just something to monitor. Wonderful. All right, great. Thank you. Peace and love.